بتاعتها.
طيب بسم الله الرحمن الرحيم. مساء الخير عليكم جميعا. أول حاجة أود لايك تساعد مستر حسن يعني منصة إبراهيم مالك على الفرصة دي. hopefully يعني it will be a useful guide for how we can approach an MRI for knee MRI I mean for patients who complaining of a knee problem. قبل ما ابدا داير ارحم على روح اخونا وزميلنا الاستاذ ربنا يرحمه ويغفر له ويجعله من اصحاب اليمين. The second thing I would like to acknowledge this most of the content of this section has been laid out by Professor ممدوح محفوظ. كلكم بتعرفوه وغني عن التعريف. ربنا ان شاء الله يجعلها يعني في ميزان حسناته. I found it really useful, interesting, simple, and straightforward. It might help us in putting some good pictures at the background. First of all, just I want you to have a look to this MRI. وداير الناس just to have a deep insight of this MRI. ترجع بين تحاول توري نفسك انك how you can approach الMRI دي بالطريقه اللي انت بتعرفها الان. try to read an MRI دي بالطريقه اللي انت بتعرفها الان. يعني how you can read this MRI using your own approach. I'm gonna see you this MRI slide at the end of the talk. Then I will leave you to reflect in yourself. What kind of a difference do you achieve, or how do you look different before and after the lecture? Okay, few seconds. Okay, let us go to first slide. This is my learning objectives. So we want to see when do we request an MRI. That is to say, what are the indications for that, and what will be the timing, and for what or who. So you know how kind of a person or what kind of a study that had been done. لأنه عارفين إنه عندنا plane وعندنا يعني using some dyes. فدايرين نعرف إنه what kind of a study that you are gonna read, and then I want to show you how you approach this kind of a study in a way. I'm not a radiologist, but in a way that can help you as having a knee case. Okay, how you can reach the diagnosis from a point of a clinician, not from a point of a radiologist. And then we're going to see if I found a pathology, what are the most suitable sites that I should suspect that I could find the slide at that. I mean the pathology at that slide. That is to say, if I have a history and if I have a good clinical examination, and then if I have MRI in front of my eyes where I could pick the pathology. Okay? So this is hopefully by the end of this talk, I'm going to give most of these objectives. So let us start by when. Definitely, if you have a case, you start by the history, and most of the most important red flags or landmarks for just what click a bell to request an MRI if your patient complains of some mechanical symptoms, such as locking, or I could feel a loose body in my knee, or the patient feeling a click or a sound. Okay? The second thing is the instability. If the patient gives you a clear history of my knee, I cannot trust my knee, or my knee sometimes gives way. From the history, then you can put at the back of your mind, this most probably this is the case that I want to ask for an MRI. The second thing, when you join your history with your clinical suspicion and examination and skills, then you find some positive tests for the structures inside the knee, whether it is extracapsular or intracapsular, or you feel something, then you can put at the back of your mind, it's another indication for requesting an MRI. Then if you have a post-traumatic case, which is extremely painful on examination, that's really difficult to elicit a single sign, then the second question is, when will be the request? This is what we call it the timing. So, as stated by Mr. Jaffer in the last lecture hosted by SOSA, the time for requesting an MRI, especially post-traumatic, is mandatory. A minimum of 2 weeks. Me, myself, usually I do request it 3 weeks or more. Okay? Then, for the time being, then I'm starting applying the principle of right and ask the patient to come back for a second visit in 3 weeks' time. By then, most of the pain, swelling of the ecchymosis and everything will settle a little bit. Then it might allow you to do some kind of a test. If it is still impossible, then you can go for an MRI. So this is when we go for MRI. To recapitulate, if I have a clear history of mechanical symptoms or instability, or if I have a positive test for any pathology inside the knee, or in case of post-traumatic cases that I couldn't reach a conclusion and the patient condition will never allow me to do the stress test, so this is justifiable to go for MRI. Typical MRI, if you don't know when do you request it, for which kind of a pathology, most likely انت ما بتصل لنتيجة. يعني you cannot reach a conclusion or you cannot reach a diagnosis because you don't know exact findings on the history, in examination, and you don't suspect anything. So when you don't suspect anything, you will never find anything. Better it's requested when really indicated. Okay? So when you have the MRI back at your clinic and then you put it at the viewing box, most of the MRI that from the start you need to declare whether it is a plane or use the dye. Sometimes outside they're using a dye, but here in Sudan we are not using an MR as progress. So most of the pictures here are plain, but you should be systematic. You should put it at the back of your mind. First of all, you have to define whether it is a plane or it's a kind of MRI approach. The second thing, you have to make sure this is the right investigation for the right patient. We are all residents. We need to check and cross-check. Usually, there is always a mistake in some reports. There is some mistakes in MRI. So you have to cross-check with the patient to make sure this is the right thing for the right patient. Then don't rely on all the studies. Sometimes patients here, they bring back MRI that backdated like 3-4 years because you cannot afford in something recent or new. Usually they bring with them all the studies that have done years and years ago. So sometimes if you do your history and you do an examination and you don't just pay attention to the MRI date, you will find that there is some mismatch. If you are lucky enough, you will find some findings that consistent with your examination and history. But better to be like a habit, check the date of the study. Then you have to make sure all the cuts are there. And I'm going to show you in a minute what are the essential cuts that we need for diagnosing the knee problem. So the type of the study, the name of the patient, the date of the study, and all the cuts are all in the envelope, including the report, are of paramount importance. So how I can approach it? Now let me show this is a plain MRI for X done on that date, and all the cuts are there. How can I approach it? This is what we call the systematic approach. When you read an MRI, like reading an X-ray, either starting from the soft tissue lead to the bone, or from the bone out to the soft tissue, either in, out, or out, in, as you like, the way you like. So the second question is the orientation of the sequence of the cut, whether it starts from the medial side or starts from the lateral side. If it starts from the medial side, there is certain shapes of the of the anatomy on the medial side that differs from the structures on the lateral side. So you have to make sure which one you are starting with, because if you figure out a pathology on the medial side, okay, and you discover later that this is the lateral side, this really will be embarrassing. So I'm going to show you how the medial side looks and how the lateral side looks. To differentiate the medial side from the lateral side based on simple anatomical landmarks. First of all, طبعا كلكم you know إنه the fibula is lateral. So whenever you find the fibula, this will declare the lateral side. This is number one. Number two, again a basic anatomical fact, the shape of the tibia at that cup. You know that on the medial side, the tibia is something like a concave, while on the lateral side it is a convex. So the medial side looks like what we call the ice cream cone. The ice cream cone. While on the lateral side, it's almost mimicking the golden stick. So if you find the tibia like a cone, an ice cream cone, this is the medial side, and the whole structure that on this ice cream cone, the meniscal, the femoral condyle, these are the medial meniscus, that is the medial femoral condyle, and so on. And if it is on the golden stick, that's the lateral side. So the structures on that side will be the lateral meniscus, the lateral femoral condyle, and by doing so, you can simply avoid misdiagnosing the pathology on the anatomical side. The third last anatomical landmark, and this is, I'm going to show you also in a slide, the shape of the meniscus. The medial meniscus usually got a big posterior hole, while the anterior hole is small. If you compare it with the lateral side, then you most likely find the anterior and the posterior horns are almost equal in size. I'm going to show you slides. Don't worry, I'm going to show you slides on that and to show you how the medial is big and how the posterior horn of the lateral meniscus is almost like the anterior horn. Go for the anatomy first. You have to know the normal anatomy. And it's recommended to go for T1. I'm not going to explain what is a T1 and T2 and other types of T2s إذا كانت stairs ولا proton density or survey. دي كلها حاجات physical. Most likely the radiologist will know better than us as a clinician in this kind of physics. But I know as a clinician, if I go for T1, then T1 will show me the anatomy. After you know the normal anatomy, then you go for the pathology. And usually the pathology appears in T2. Then you have to have like a global image interpretation. That's what I call it. Global image interpretation. Don't take a pathology on one cut. For example, if you find a signal on the posterior horn of the medial meniscus, on the sagittal, put it at the back of your mind, then go for the coronal, although the sagittal is the best side for the to see the posterior horn medial meniscus. But if you take in consideration the coronal as well, this is will help you in sometimes giving more information about the pathology. So you have to have like a systematic approach. Then you have to know where is the medial and where is the lateral, and then you start with T1. Then you go for T2, and then you have to combine T1 with T2 with in three anatomical cups: sagittal, coronal, and axial. So, as an introduction for this lecture, the MRI protocol, you should have all these in the envelope. You have to have like a sagittal, the coronal, and the axial, and each one of them, they should have at least T1 and T2, and if you want a gradient or a stair, then you can ask for a gradient or a stair. If the radiologist or the technician is wise enough, if he found a pathology, he will know better that when he requests a stair or the gradient for you. So it will help you reaching the diagnosis. But nevertheless, accept a cut which is really not well done, or a badly taken slide, or a missing slide. This is really, it puts you in a dilemma. This is why I think most of the clinicians here, they don't rely much on the MRI, because I don't think they don't know, but they not reach a conclusion because the cuts are not complete. So we need to train ourselves how we can read an MRI with the proper MRI protocol. Going back to the anatomy, just to refresh our minds and to start like warming up. This is a knee slide. It shows you the extra-articular ligaments, the intra-articular, the cruciates, and the meniscal. So let us start with the meniscus. How it looks. Let us start with the medial meniscus. لأنه based على الاناتومي ده زي ما قلت لكم في T1, then I'm gonna diagnose whether this meniscus is normal or whether this ACL is normal or not. Let us take the medial meniscus. The medial meniscus is more or less, it is here, in the upper left corner, more or less like a banana shape, having a big posterior horn and small anterior horn. Okay? The posterior horn is thicker than the anterior horn. And this might be something funny and related to the stability of this. The medial meniscus is the secondary stabilizer of this. On top of the main stabilizers, the ligaments, dynamic stabilizers, we have the static stabilizer, the ligaments. The meniscus could be regarded as one of the ligaments, intra-articular ligaments, that playing a role in knee stability, especially the secondary. That's what we say, the secondary means that the primary stabilizers, the cruciates are intact. If the cruciates gone, then the posterior horn of the medial meniscus will become the primary stabilizer. And that is important because if I have an ACL deficient knee, in most of the cases who present late, usually they do present with a type of a tear, could be simple, could be complex in the medial meniscus with some osteoarthritic tear or degenerative. So the medial meniscus, like a banana shape, have a posterior horn bigger than the anterior horn, and this is how we can differentiate the medial from the lateral, as we have said in the MRI finding. Okay? And most of the tears on the medial meniscus usually degenerate, while the lateral are traumatic. This is general tear. The medial meniscus, as you know, is closely attached to the capsule with a lot of ligaments, coronary ligaments, and transverse ligaments, and we have other ligaments that's related to the PCL, the Westbury and the Humphrey. Okay? With little excursion inside the knee joint. If you compare it to the lateral side, which have more mobility, with better excursion and more excursion, almost like 10 times the medial. 10 times the medial meniscus. This can explain why the medial meniscus at higher risk of injury than the lateral meniscus, as you know this piece of. Okay? Anatomically, we need to know the medial meniscus like a banana shape with bigger posterior horn and smaller anterior horn, and have a role in the stability of the knee, and we call it fixed. If you can say fixed, with less excursion if you compare it with the lateral side, and the degenerative tears are by far the commoner type of tears than the lateral. This is to apply what we have said about the medial meniscus. Why we know this is the medial compartment? Because definitely there is no fibula here. the tibia looks like an ice cream cone. The posterior horn of the medial meniscus is bigger than the anterior horn if you compare it with the lateral, as you will see. So this is the medial femoral contact. And if you have a pathology on this, then you can see confidently this kind of pathology. For example, there can be any osteochondral defect, which by far the commoner. See, in the medial femoral condyle, if you have a kind of a fracture, like Hoffa fracture or whatever, then you can say confidently this is a fracture in the medial femoral contact. Okay? Let's go for the lateral meniscus. If you compare it with the medial one, it's like a C-shape. That is to say, it's a uniform kind of a disc that is and from posterior to anterior, having the same thickness and the same size. This is why you have a cup, then the posterior horn more or less mimicking the anterior horn. Sometimes it might be hypoplastic. Some of the degenerative, problems or developmental problems that it can happen to the lateral meniscus more than the medial meniscus. The discoid meniscus by far is the classical example with the meniscal cyst. So the discoid meniscus and the cyst usually are commoner in the lateral, but it doesn't mean that the medial meniscus will never have a developed, underdeveloped meniscus or to have a discoid meniscus. Again, the cyst could happen on the medial side as well as the lateral side, but by far it is more common on the lateral side. Let us have an idea about how the meniscus gets its blood supply. According to the blood supply, you can divide the meniscus into 3 zones. These 3 zones usually dictate the type of management that you can offer for your patient. Let's say if you have a patient and you have a medial joint knee pain, and then you examine him, it is a clear, straightforward medial meniscal tear, and then the MRI came back with this kind of a tear, then you need to determine or you need to ask yourself whether a tear on the peripheral zone or on the central zone. If it is on the peripheral zone, that is to say here, what we call it the red zone, usually there is a higher potential for healing, so you can offer him some sort of repair. But if you have it in the central zone, which is, we call it the white zone because it is void from the blood supply, usually we can offer him what we call partial meniscectomy. Okay? Because here the probability of healing really, or potentiality for healing is really low if you compare it with the peripheral zones there. So according to the blood supply, we can divide the meniscus into either a red zone, which is rich, closer to capsule, with your blood supply, or a white zone, or there is an area in between that we call it red-white zone. So we can repair up to here. Here, either repair or partial meniscectomy, it depends on how regular is this. Most of the time now, you can offer the patient some kind of repair or reconstruction, and then you can wait for the result. Still, the meniscal outcome, whether a repair or partial meniscectomy, especially in this area, is an area of controversies and an everlasting debate. Still, the outcome is not that really, but most of the studies are in favor of a repair rather than, especially if it is regular, rather than partial meniscectomy. So if I want to see the menisci on the MRI, how it looks. Usually this is, as I've said, you have to have like a global approach. You have to go through the cuts. The shape of the meniscus on the MRI have different, the meniscus have different shapes on the MRI, it depends on the size of the cup. When it is closer to capsule, that is to say this is cup C, usually you can find it like 1 unit. And this is usually either at the beginning of the study up, the upper left corner or the lower bottom right corner. Usually you find this shape. In between, then if you go for B and A, then you can find the typical shape of the posterior horn and the anterior horn, just like that. putting in mind the anatomical shape, the medial have bigger posterior and than the anterior, while the lateral have the same size of the anterior and posterior. But if you find that this is straight, one piece of the meniscus have been found in more than one country, that means this is abnormal meniscus. This is how the discoid meniscus looks like, as I will show you later in the MRI. It is normal to find one fibrocartilage at 1 or 2 slides maximum, but nevertheless more than 3. Then it starts the proper cut to show you the anterior and the posterior horn. And you should follow the shape of the meniscus should be like a triangle of a pizza. Should be very nicely laid triangle with all the sides of the triangle being completed, and it is contained. This color is well contained inside. You will never find a white color inside this blue color. So it should be homogeneously black on the MRI, as I will show you. Usually the normal structure looks like black. Here it is just a blue for explanation. Yeah? First, one disc, then will be the cup will be like that. So this is the lateral meniscus. Why it is a lateral meniscus? Because the fibula is here. The shape of the tibia is more like a golden stick, and then the posterior more or less equal to the anterior. And this is the slide that I show you. The more lateral you go, you will find it like one fibrocartilage disc. But when the cut goes on or goes by, then we find a typical anterior and posterior distribution. Okay, so this is the menisci, how they look, and how the blood supply will be looks like. This is a slide just to compare the medial and the lateral. Again, how I know this is the study starts from the medial or lateral. Let us rehearse it together. Our حاجة, the fibula should be somewhere here. The shape of the tibia different. Here like a hockey stick, while here it is like an ice cream cone. Then we go for the meniscus. We find that the medial posterior horn is bigger than the lateral posterior horn. So confidently then I can say this is the medial side, where this is the medial femoral condyle, and any pathology that happens in this area I can interpret it or located in the medial side, whether on the femur. This is the lateral side, and you have to look for the corresponding pathology on that side. The cruciate. The cruciate, this is an intra-articular structure. We have like a set of two. We have the anterior cruciate ligament and the posterior cruciate ligament. Usually, whether it is an anterior or posterior, usually related to the tibial insertion. The tibial insertion. The same for the bundles of the ligament, whether it is an posterolateral or anteromedial bundles, and the opposite on the PCL. Again, the naming came from the tibial insertion. So the anterior cruciate usually starts from the anterior side. If you find a rope, a black rope like that, coming from the anterior, white is anterior because the patella is right here. Okay, this is the anterior, and white is posterior because it's far away from the patella. So the anterior cruciate ligament usually it appears on the notch side. And you finish, if you go from the rows of the MRI, whether it is starting from the medial or the lateral, then you can find the after you enter from the compartment, then you enter the notch view. Then you find on the notch the structure that you know, which is the cruciate. It depends on from where you start. If you start from the medial side, definitely you know that the BCL will come first. لأنه attached and medial femoral condyle. That is to say, the lateral aspect of the medial femoral condyle. يبقى انت جاي اذا كان الكف جيت from medial to lateral, then you find the BCL. وليه بيكون واضح اكثر؟ لانه يا اخواننا يعني هذا wide insertion thicker than the ACL and easy to achieve or in the cuff. Unlike the ACL. الACL بتحتاج sometimes what you call اذا كان التكنيشنز بتاعك ما عارف مرات بيجيب لك very bad cuff. ليه؟ لانه simply القط بتاعت الجهاز ما خدتها مع الاكسس longitudinal axis of the ACL. That's called the scout oblique or scout segment. So it put the axis on the ACL so as to show it the ACL. Definitely the BCL will appear somehow somewhere. The proper ACL usually after you have done with the BCL intervention from medial to lateral, by that you can count 1 to maximum 3 we find the ACL. Or if you start from the lateral side, يعني you find القصة اللي هي تشبه lateral compartment on the top of the film, then most probably this is the lateral. You then get ACL. Sometimes if you don't find it, count like 1, 2, 3 cuts on the notch, you will find definitely the BCL, then you can count back, you go back again through the cuts to find where is your ACL. The normal ACL or the BCL or the meniscus usually should appear black. They are black. When we talk about the MRI, بنتكلم عن intensity. The black is hypointense, while the white is hyperintense. White is black. الفيزيكس بتاعت الام ار اي depends on how much is the hydrogen ion on the structure. وما بتلاقي الا لما يكون في fluid content. تمام؟ عشان كده wherever you found fluid content usually find it white which is hyperintense. عشان كده دايما بتكون pathological. لكن اذا كان الستراكشر بتاعك black, there is no fluid inside. Okay, معناها this is a normal, should be hypointense. عشان كده generally بنقول أي black structure inside the MRI usually this is a normal و you can دايما بتلقاها في السكيما. لكن إذا لقيت أي white signal inside usually it is possible. طيب, for the ACL orientation usually the normal ACL on top of being black يعني لابد يكون homogeneously black. اثنين المفروض you have like a good tension from anterior to posterior. And usually it follows what we call a Blumensaat line, this black structure. Usually the ACL should follow this black line, the Blumensaat line. If you find the ACL like black, with a good orientation, يعني جاي من anterior ماشي posterior, and have a homogeneous color, and have a good tension, this is a normal anterior cruciate ligament. Again, the BCL have the normal course, which is from posterior to anterior, either a comma shape or figure of 6 in Arabic. Usually have a homogeneous black, and it's more obvious than the ACL. This is a normal ACL and a normal BCL. But if you have there is some change in the color, or in the course, or in the tension, then you can declare this is most likely this ligament is not normal. يعني شنو؟ يعني إذا لقيت الكورس بتاعه instead of going this oblique following the Blumensaat line going more horizontal, or instead of being homogeneously black it's being white, or it's not in a good tension, it's a good torsion, or لقيت some laxity on the BCL, the more buckling BCL, usually radial BCL of this kind of attack. لأن دايما بنلقوا مثلا لونه ما أسود بيكون أبيض بيكون دايما بيسموه cloudy ACL. Simply sometimes ممكن يكون normal ACL, especially if you request an MRI early on, لأنه مع الإديمة بتحصل مع التروما usually يكون fluid everywhere. Okay, so you can interpret a cloudy ACL as a complete tear. So you need to sit on that acute injury, treat it conservatively for like 6 weeks, 3 to 6 weeks. Then you can ask your patient to come back for doing an MRI. So then, if it is white, you can say together with the clinical examination, it's solved, or you can say this is a partial tear if it is like a normal finding. Okay. So this is an MRI. Let us just say this came together, how we can approach it. So this is a plane, okay, like T1 is a kind of identification. Then you can read from this small busy letters here, okay, the orientation, whether it is right or left, or sometimes up here in the corner. Then you can identify the name of the patient, the date, okay, on which that's being done, and then you can go straight away to a systematic approach. This is starting from which side? Lateral or medial? Obviously it is the lateral for the reasons that we mentioned. So this is the lateral meniscus, and this is the lateral femoral condyle. This is going from the cuff in the second line, which is this notch. Okay, since it starts from the medial side, then expecting to see the B cell first, then we'll go for the A cell. Instead of going this, معناها MRI دي ماشية this way. Okay, يبقى this is a good MRI. Why? Because the A cell is clear, it is following the fluorescence line, have a good tension and a good orientation. This is just to apply what we have said in the previous slide. Again, compared with this. So, if you say this is a medial or lateral, obviously it is the medial. Why? For the reasons that we mentioned. So, where is the anterior hole? Sometimes it's really hypoplastic like this, bigger posterior, smaller anterior. Then see the posterior cruciate first. Then where is the anterior cruciate? Should be here. Absent. Since it is absent, this is indicate third. Then we'll go for the lateral spine. Definitely, this is the sagittal. ما تعتمد على زي ما قلت انت, you have to have like a global look for the forehead. Again, an MRI. Let us skip that. Going for the patella or the femoral joint is one of the most important parts of your examination. Then after you have said that, the knee examination is not finished unless you examine for the patella. Usually it is missed. You have, it's a common size for there is a lot of pathologies that causing some pain to the patient, or the patient have instability. And كده دائما any giving way doesn't mean that it's an answer. Sometimes the patella dislocation being called as can cause some kind of a sense like a giving way. So this is a normal patellofemoral joint. Then you can see it is like a normal. يعني شنو يعني the patella is here. You have like you have to look for the tracking, the medial articular size, the lateral articular size, the retinaculum here, which should be normal if they have lump pathology like that, or have like tilting. You have to mention all this from the axial cut. So how is the structure that appears on the MRI? Okay, if you find that you have T1 and T2, if you have like a black line or black structure, this is قلنا هتكون normal. دائما you look for T1 or T2. دائما بتكون either cortical bone, يعني كل الأسود ده عبارة عن cortex. This is the cortical bone. This is the cancellous bone. Okay. And again, if it is a normal meniscus, then I should see black, as I said, the ligaments. And if you have calcification, special calcifications, يعني إذا لقيت calcifications في الميديال collateral ligament, دائما it happens post-traumatic, دائما it appears black. لكن طبعا better, before you reach a diagnosis of calcification, better to have like a basic X-ray for the knee. لأنه calcification usually appears better in the X-ray rather than the MRI. So أي حاجة have low intensity, this is normal. Okay. طيب نشوف الحاجات النورمال وفيها high intensities in T1 and T2. دائما الفات has a high intensity in T1 and T2. The motor again have high intensities in T2 but have low intensity in T1. يعني شنو الكلام؟ يعني الفات دائما appears white. لو دايما تعرف الحاجة تلقاها دائما في المظلة، بتلقاها في السبكوتينيوس، بتلقى دائما في white color. كويس. This is indicates fat. Okay. الووتر if I have a trauma، يعني حاجة intramedullary congestion يعني post traumatic، or I have a fusion inside the knee joint. Usually في T2 appears. أنا T2 قلنا دائما تورينا الباثولوجي، وأي باثولوجي usually في white. يعني has a high intensity. اوكي طيب وفي التي 2 دايما have low intensity appears flat. So الفات is normal والwater is pathological. How I can differentiate a fat from a water? Then I can call for what we call a fat suppression view. يعني بياخذوا view بcertain physical يعني formations. Usually they suppress the fat, what we call a star view. This is star view. It shows you the fat as black, that is to say low intensity, while the water is still white. عشان كده دايما لو عندك اي post traumatic لقيت فلير يعني كل ال MRI film it looks white, usually this is a post traumatic. Usually it is a post traumatic. Or sometimes an infection, although it appears like a flare everywhere, it's white in every place, nowhere في كل حته. عشان كده usually this is possible. So إذا كان عندي في T2 و T1 high intensity white structure, this could be fat or it could be water. So if I go for T1, then I found the high intensity, like low intensity black, it tends to be black. This means it's water. Okay. Again, if I have to differentiate between the fat and the water, then I will ask for the stir view, which appears white. In the stir view, usually it is water, while if it is appear black, which is high intensity, this is fat. This is apply. Okay, this is T1. Then there is a proton density, a variety of T1. All of these we call it a variety of T2, whether it is T2 or a gradient or a star. Okay, this is normal meniscus. Why? Because it appears black. This is abnormal meniscus because there is some white line here. This is a normal tibia, while you can see this is some congestion. This is water outside. All of these are possible. If we find that in conclusion, any black structure, that is to say high intense, is normal, still prove otherwise, while every white is pathological, still prove otherwise, except if it is fat. So this is how it looks. Okay, the MRI for T1, T2, and a proton density. Then لابد اعرف انه انا اي structure اشوف وين. يعني عندي menisci, عندي ligaments, عندي tendons, عندي bones, عندي with the fluid inside, that is the synovial diffusion. I have to choose. عشان كده قبل انا ركزت في قصه you have to have like a global interpretation for each structure. Sometimes you need to support your diagnosis with another cut. For example, the menisci usually the better to see for the menisci on the sagittal. The sagittal cup, as we showed it earlier, that appear better on the menisci appear better in the sagittal cup. But sometimes you need to go for the coronal cup. Sometimes you need to go for coronal cup. The ligaments برضو أحسن حاجة إنك تشوفها for the cruciate تشوفها في الساجيتال. الكولاترال دائما بنشوفها في الكورونال. والريتيناكولار as we show you the slide of the patellofemoral, usually we say we should see it in the axial. The tendons like the quadriceps and the patella better to be seen on the sagittal, the bones better on the sagittal, and if you have like a synovial diffusion again, better on the sagittal. So the sagittal is really a cornerstone in the MRI protocol. You can ask for the يعني إذا كان خيروك قال لك نعمل لك الخيارات يا مقطع يقول لهم دائما السجدة دائما يدوك له يعني T1 T2 whether you have like a proton density for T1 or you have like a stair or gradient for T2. Then if you have to support your diagnosis, you have to go for it. Or if you want to see the collaterals, then it's better to ask for the corona. And if you have like a patellofemoral problems, especially for young females coming complaining of anterior limb pain, you have to stress on the axial. So hopefully everyone is following. I know I'm really detached from the sound. Harry? Okay, Harry?
Yeah, okay.
Everything is fine?
Yes.
بالنسبة للتايمينج because it's a big lecture, usually I've divided into 3 parts. Now that could be like an introduction. If the time is allowing, then we can go for part one, and then we can see whether we have time or not.
Yeah, you could proceed. Yes.
طيب عندي كم زمن؟
ممكن 20 minutes.
20 minutes. So our precise اللي هي نحن الكلام اللي قلناه ده يا شباب هو is really an introductory piece of this talk, وهو اللي بيعتمد عليه really أكثر من 50% of your approach and diagnosis of the MRI. الباقي ده هو more or less that was the normal. This is to show you the pathology. شفنا الصور قبل كده وعرفنا كيف نقراها, how we can proceed. الجاي ده just to show you the pathologies. هنبدا بالفيرست part اللي هو mainly about the meniscal. ready يا شباب؟ ready يا بحاري؟
Yes.
Ready?
Yes.
Okay, let's go. Now here we go with the meniscal tears. We started بالanatomy with the medial meniscal. Okay, and then a types of the tears, usually there are many, but in general we can divide it into either a traumatic tear, we stress on that, and medial meniscus have secondary stabilizing role, and if there is an ACL deficiency, usually it will become the primary stabilizer. So it will be at high risk of having this kind of a tear every given way. This meniscus will be being patched between the femur and the tibia. So the traumatic tear by far could be there. Again, the degenerative tears is the medial side, have a high stresses and accommodate a load, especially in a varus knees or a heavy weight patients. Usually the medial compartment have much more than the lateral. That one of the functions of the meniscus that to absorb the shocks and to distribute the weight equally on the tibia, hip hop stresses. Okay. Again, the medial meniscus is not immune from the cyst or a discoid meniscus. I've seen one in my career. Okay, I've done just 2 weeks ago a medial meniscus with the typical discoid shape. So the discoid shape is not only for the lateral meniscus. Again, the medial meniscus could have this kind of a discoid changes. Okay, so let us see how the tears looks like and how the degenerative tears looks like, and the cyst and the discoid. So these are the types of the tears. Being described based on the MRI on whether there is some change in the color inside, okay, or according to the line of the tear. يعني إذا كان عندي change، يعني إحنا اتفقنا إنه the meniscus should be a good homogeneous triangle, complete, no single defect, or there is no disruption of one of the borders of the triangle. Okay, should be contained and should be homogeneously black. If there is a signal inside, that is to say not exceeding more than 50% of the width, this you can call it type 1. And this is something subjective usually. Okay, what is type 1 and what is type 2? This is maybe something that you can differentiate by your experience. But this is a small spot usually. Here you can call it type 1. If it extends, most of the black area here, but is still contained within the triangle, this you can call it type 2. Okay? When this kind of a white spot is reaching either this surface or this surface, then we can call it type 3. In type 3, it depends on this line. If it is a one line, then it's like a simple tear, then there is different shapes of a simple tear. Or if there is more than one line, that is, we call it complex tear. We have one in the type 1, in the type 2, in the type 3. Before we go from or we leave this stage or this slide, انا بس داير اذكر انه يا اخواننا usually type 1 in most of the cases you find like a normal variant. يعني it's a normal variant. يعني sometimes you find some patients have a good rich blood supply to this area. Okay, especially in pediatrics. If the type 1 in pediatrics could be normal, and this is nothing but increase of the blood supply of that area. So don't rush for diagnosing your patient as having a meniscal tear, especially if he's or she is not symptomatic, and then you base the whole workup or the workout as having the meniscal tear. Then this is a normal tear. You have to have a good history doing examination, and then lastly you can just add the MRI as adjunct for your also support your diagnosis. Okay, this is the types of the meniscus if you took it like that. Okay, this is CD, this is the meniscus, this is the medial side, this is the most peripheral side, all this is the central, this is the most peripheral, then this is the kind of a change that you'll find. And this is just nothing but an increase of the water content inside. You know, يعني meniscus usually have a matrix, the broad fibroelastic cartilage, okay, which type 1 mold, like 90%, and it have a good type of fiber orientation. We have basically what we call the radial, okay, and the circumferential or horizontal fibers. If there is some separation, the cross-linkage between these fibers and increase in the water content because of the increased stresses on that meniscus, then the changes started here. If the stress is gone and this linkage had been more detached or more hurt, then you can reach up to a point till you have like a two lamina, and then this two lamina is going fixing on each other till it reaches the end of the surface, then it becomes like type 3. This is how the pathological degeneration goes on if the stress is still being applied on that meniscus. It's the meniscus. Okay, this is type 1, this is grade 1, grade 2, and if it is out, then it will be grade 3. This is grade 3 as well. I have more than one slide for the same pathology so as to consolidate. Okay, this is again type 1. Okay, this is, you can see it's type 2 extending up to here. It's approaching almost type 3. And this is which type? This is type 2. Okay, and this is meniscal striation usually. And I put a triangle, and it mimics the pizza triangle. It should be homogeneous in black. And this is, you can see this black, there is some gray area here. And that is to say there is some striation and increase of the water content on the peripheral side. Again, this is one of the most common changes that is happening. Again, this is striation of the end. Now, if the tail had been extended, started as this is small, this extended all the way from the peripheral to medial. So we have like two leaves here. Which one? This is on the tibial side, this is on the femoral side, this is almost type 3. قلنا زي ما قلت لكم يا اخوانا في simple type if it is like one line, and if it is more than one line will be complex, and there is a special type diamond being described according to the shape. يا اخوانا, and now two types of a simple line, and this is type 3, this is type 3. Well, instead of going from peripheral to peripheral to central, it could be up and down orientation, yani going from the femoral side down to the tibial side. And this is what we call a vertical tear. If there is a kind of tear going through the longitudinal axis of the meniscus, this is, we call it horizontal tear, and usually it is a degenerative tear, usually due to long stresses, okay, acting on that meniscus. Or it could be a vertical tear. Usually vertical tear goes with the traumatic tear. So what is the radial tear? The flap has been just detached from. This is a horizontal tear. This is again a horizontal tear. okay, going all the way from the medial or from the peripheral to central. This is another example of peripheral tear, horizontal tear going from peripheral to central. This is another example of it. So if you have like a triangle has been divided into two, with this white structure, usually when any white structure usually is a pathological, then you can say this is a tear. Okay, this is a vertical tear as is shown here. Okay, you see this is part of the meniscal, this is the other part, and there is some vertical tears here. Well, by far, most of the meniscal tears usually it happens in the red white zone here, while like 65, while like 35, something like that, it happens here. So most of the tears usually find it in the central rather than the peripheral. While the peripheral have a good outcome, while the central have in the middle red zone maybe 50-50, while in the white zone that the potentiality for healing is really low. Okay, this is another example of a vertical tear. Usually it is traumatic, as we have said. Okay, you find a white line that is bisecting this nice triangle into two small here piece, and another of the triangle has been medially. So this is a traumatic tear of the medial. Again, this is a traumatic tear. طيب داير هنا اللي جبت كورونا اللي جبت سيد just to show you sometimes if you have a tear, okay, you need to compare it with the coronal. Again, you find the orientation of the tear, either it is vertical or horizontal. And you have to have like again a global interpretation. You see it in the sagittal, you find it like RS3, then you have to confirm it on the lateral side. And this is the same applies for other structures. Because sometimes الكورونال بالذات بالنسبة للميديال meniscal tear of paramount importance. Especially now يعني في coming concept of a posterior root tear يعني gaining popularities في الترند بتاع الريبير والريكونستراكشن كويس, and usually the best cut that to see the root tears usually will be on the coronal. So this is the vertical tear has been seen on the sagittal and the coronal. So what is a ghost meniscus? Ghost meniscus is simply absent. Absent meniscus. Okay? So then usually this is one of the things that you find it in the what we call posterior test. What you call a ghost meniscus. يبقى إذا لقيت anterior hornless أو ما لقيت posterior hornless you call it a ghost meniscus. Sometimes not بتلقاهم لكن بتلقاهم excluded outside. يعني شنو بتلقى الميديال meniscus excluded يسميه medial meniscus exclusion outside and the lateral. This is it happens if I have a tight joint space. وده دايما بيحصل بتين if I have an osteoarthritis. يبقى إذا لقيت إنه الجوينت سبيس is narrow and لقيت المنسكس يعني extremely excluded outside, this is a kind of pathology that it indicates narrowing of the joint line and well-established osteoarthritis. This is one of the problems of doing arthroscopy in a narrow joint space in osteoarthritic knees. Usually the problem starts from this narrow space. عشان كده دائما يعني an indications for arthroscopy in an osteoarthritic knees usually had been on the decline. not يعني falling out of favor and usually the outcome بتاعي is not that good. So people now they're going away from doing arthroscopy for osteoarthritis. This is fairly common type of special meniscal tear. That's what we call it the bucket handle tear. bucket handle tear يعني هو نفس الhorizontal لكن the body of the tear had been detached from the mother body of the so it becomes like a handle of a bag. Okay, this is what we call it the bucket handle tear. So it's really one of the we can call it top potential emergencies or top emergencies in arthroscopic setup or a patient with meniscal tear, and sometimes had a really painful presentations in what we call a locked knee. It's called locking of the knee because if this is prolapsed inside the notch or displaced inside the notch, then it prevents the knee from full extension. pathological specimen. So we're going to show you how it looks on the MRI. Again, we call it fish mouth there. This is a description. And what is an MS separation? Meniscal capsular separation. This is by far more like a bucket handle tear, but instead of having the level of the tear at the red wide zone or the red wide zone or red wide zone and wide zone, you will find the separation from the capsular side. And this kind of meniscal capsular separation really a tricky kind. Patient presented with a typical history of locking or pain or catching sometimes or clunking or a sound clicking. Then when you do the arthroscopy, you find everything is normal. This is a kind of pathology that you can never predict unless you probe the meniscus. Then you can say the translation of the meniscus that exceeds the summit of the femoral condyle, the maximum point of convexity of the femoral condyle. If it exceeds this point, most likely this is the cause of the pathology and the cause of the clicking and the cause of the locking. Again, it needs some repair and the outcome will be good. Okay, this is the fish mouth that I've shown you before. This is a radial tear. This is just a description of a different types of the tear. And this is how the bucket handle. This is started as type 2, then it starts to increase till it reaches here and there, and then it gets separated till have locking inside. So how it looks on the MRI? إذا كان عندي bucket handle here on the MRI, how I can diagnose it? قلنا يا اخواننا دايما إذا كان في الميديال سايت والبيشنت جاي complaining of locking and the maximum point of tenderness دايما في الباكيت هاندل ما بتلقاها في البوستيريور هورس، بتلقاها دايما more or less towards the center. يعني شنو قدر ما تمشي على الباتيلا بتلقى دايما it is a point tenderness closer to the patellar tendon. ما زي البوستيريور هوم ميديال meniscus. أنا I'm not saying that absolutely. لكن sometimes you can find pain at the periphery, but most of the patients presented with bucket handle tear, you find a point tenderness on the anterior knee closer to the patellar tendon. As you see, if you press deep, okay, following the medial meniscus from the posterior side all the way to the anterior side, you will find somehow a point of tenderness closer to the notch. Okay, this is on your exam. And then you can find position بتاعها in 15-20 degrees flexion, deformity. Patient cannot fully extend it, and if you give him a trial just of press the knee suddenly or a jerky kind of a press, it springs out. And if it springs out, when you push it, the patient starts to feel pain, and the knee it recoils back or it springs back into this flexion deformity, so they cannot and cannot reach the full extension. Okay, if you find the knee flexion deformity and it springs back, this is again a sign of bucket handle tear. When you go for the MRI and you have it from the history and then you see the examination بتاعك, you are predicting in this patient have a locked knee because of the medial meniscal tear لأن لقيت الفاينل سجلناها. لما تمشي للميديال side انت expecting to see this huge posterior horn, triangular shape, black meniscus, then you find it small, decreasing the size. وما بتلقاه full shape triangle، ممكن تلقاه more or less like a rectangle or حاجة كده هيك، يعني it's not a proper triangle, especially the outer, the most peripheral part. لأنه أساسا التيب of the triangle اللي هو الجزء السنترال يعني من الريد زون or الريد وايد زون or الوايد زون دائما هي اللي بيحصل لها detachment from the body of the meniscus or another body of the meniscus. Then it goes medial. Okay? On the sagittal لأنه إذا أنت تخيلت إنه this splitting of the bucket handle it goes inside the notch. What happens؟ بتكون دائما يعني it goes from anterior to posterior. If you like a C shape وحصل الديتاشمنت ده دائما بتكون standing up from posterior to anterior. بتكون in a way that is parallel to the PCL. عشان كده دائما لما تمشي لل MRI sagittal cup starting from the medial side لقيت المنسكس decrease in size لقيت double apical sign double posterior cruciate ligament sign لأنه الاورينتيشن بتاع الحتة اللي اتقطعت دي دايما it goes from the posterior part to anterior part only هي ماسكة في المنسكس بالanterior والposterior part عشان كده بتكون هي like a bucket handle going from anterior to posterior. This is why it looks like a posterior cruciate. عشان كده جات لنا التسمية بتاع double BCL sign. It mimics on the MRI like the BCL. Okay? بتلقاها دايما الستريس جديد. يبقى إذا لقيت السايز إذا لقيت this double BCL sign usually you can confidently diagnose this patient have a bucket handle test. Again, if you go for the coronal, you can see the meniscus is not complete. بتلقى منه جزء goes inside the notch. يعني دائما في النوتش view بتلقى black spot attached to the condyle whether medial it could be the BCL ودائما بتلقى تحتها black another spot يعني double black or double hypointensive structure usually most likely this is a bucket handle test. Okay? دي اللي قلت لكم قبل شويه انه بيحصل لها detachment from the mother then it goes anterior لانها ماسكه في الانتيريور والبوستيريور usually it goes this way والplane ده usually it's you know it is being parallel to the posterior cruciate عشان كده الام ار اي بيديك الدبل posterior cruciate ligament دي الحته اللي قلت عليكم انه بتلقى small هي اوكي لو مشيت في الكبسه مور كلوزر posterior بتلقاها triangle بتلقاها دايما detached اوكي تلقاها flipped inside instead of having this nice layout okay تلقاها دايما flipped inside and this is what is a BCL sign looks like okay تلقى nice this is part of لكن still you can say confidently the triangle is here it's not flipped inside the notch لكن اذا لقيت this piece only ودي لقيتها ما فيش دايما بتديك حاجه بالشكل ده يبقى يا اخواننا مع اي لوكينج كويس ممكن at the time of the MRI ممكن حصل لهم unlocking والحته دي رجعت قاعده في الحته ممكن تديك شكل زي لكن اذا جاء كلينيكالي كويس وستيل الام ار اي looks like that معناه this is unlockney وغالبا بدات خشت في السجن انه خلاص get stuck انه ما بترجع ثاني عشان كده you have to go for arthroscopy. Okay, this is one of the potential emergencies in arthroscopic setting, a locked knee. You have to operate on it. Normal at in the night, in the middle of the night, لكن usually has been done as soon as possible. Okay, it's another example. This is the black spot that I tell you about. بتلقى دايما المنسكس it's small. It's not like if you compare it with the lateral side. Then بتلقى جزء منه clip inside the notch, and this is the BCL sign, the double BCL sign. Okay. Again, okay, this is obviously a double BCL sign. Okay, this is another one, the coronal you can find. This is the BCL black spot hypointense. تلقى تاني تحتها زي black spot here. تمام؟ This is the bucket handle there. تلقى دايما the peripheral part is smaller if you compare it with the other side. Again, okay, you see? This is complete meniscus, the lateral. What about the medial? There is a tear here, starting to have like a BCL sign. Like you can see here, it's full blown picture of a BCL sign. الحتة الصغيرونة دي is it a BCL sign? دي sometimes إذا ما لقيت معاه الحاجات ولقيت small piece of it دايما تكون لي misleading اللي هو دايما ال preserved ligament اللي هو one of the ligaments that linking the medial meniscus with the cruciate. Okay, فدي واحدة من ال stabilizing factors normal pairing you have to be careful about that. Okay, you have to عشان كده قلنا دايما ال global interpretation of the sagittal together with the coronal it give you a good insight. الميديال meniscus دايما هو الباكيت هاندل common في الميديال meniscus لكن this is it doesn't mean that it will never happen في اللاترال meniscus. أنا جبت السلايد it's rare one of the difficult type of really tear that we can deal with. Medial meniscus bucket handles to some extent that we can suture up to here. Like in a lateral meniscus, if you don't have all inside, usually it's a problem. And if you know that the risk of developing osteoarthritis, if you take this out in the lateral meniscus, is far by far more than the medial meniscus. يعني بكثير. لكن طبعا الاوستيوارثرايتس يكون في الميديا compartment. لكن if you have like a partial meniscectomy on the lateral diamond, the risk of osteoarthritis is faster and even more aggressive on the lateral side if you give this patient an option of partial meniscectomy. So what we call the double, the Beckett handle tear, or if it happens on the lateral side, usually we call it double delta sign. This is triangle and this is triangle, and then the posterior is small. If you have like this double delta sign, this we call it. We can diagnose it as a Beckett handle tear lateral. Again, this is a double delta sign, posterior absent, anterior double delta sign. Then this is how it looks on the diagram. What other pathologies? عرفنا التير، عرفنا it is traumatic or degenerative، عرفنا it could happen on the medial or lateral، عرفنا قسمنا ال types of meniscal tears عندنا either to the if it is contained inside into type 1 to type 2, if it extends more than 50%, if it exceeds the 30, this will be type 3. If I have like one line, this could be type 3 simple, or if there is more long-standing injuries and more repetitive injuries, this one line will be more than one line. If it's secondary line, this will be a complex tear. Different special types of meniscal injuries. By far the commonest ممكن يكون the bucket handle tear في practice, and this is we rely on it, or we put much stress on it لأنه واحدة من potential emergencies. You have to know how we can diagnose the bucket handle tear, other types of tears, cardiac tear or fish mouth tear. These are all descriptive tear for the meniscal tear. This is regarding the horizontal tear. Another type of a tear, which is a vertical tear, usually by far is a traumatic tear. This type of tear could happen on the medial or lateral side equally, like in by far degenerative on the medial side, while it's traumatic on the lateral side. Okay, so other pathologies اللي هي discoid والcyst. This is how the discoid looks like. This is a pure developmental problem. Usually, this is intrauterine kind of shape of meniscus. Then when the baby being born and when it grow up, he or she grows up, then this size will be taken out or eaten out to reach the normal shape, which is a banana shape on the medial and a T shape on the lateral. Sometimes for a reason or another, it remains like that. And the problem of this might be it might be asymptomatic, but the problem is that when it starts, the patient to have some concern, or he starts to hear some clunks or clicks, or starts to have locking near extension. Most of them, they are young guys. That doesn't mean that it will never appear in late adulthood. Sometimes we see patients in late adulthood in their 30s or 40s with features of discoid meniscus. This is how the discoid meniscus looks like. And the problem of the discoid meniscus, usually patients will have some concern about this odd sound on the knee or the mechanical symptoms. How I can diagnose it? Usually, it happens near extension, 10 to 15 degrees near extension, and then you can find, if it is on the lateral side, then you can find tenderness if it's been locked on the lateral side. But as I said, usually the medial meniscus is not immune against the discoid meniscus. How I can diagnose it? You suspect it from the history and your examination, typical age of the patient, typical presentation. Then better to ask for an X-ray. There is certain X-ray signs like squaring or cupping, or squaring of the medial or lateral femoral condyle and cupping of the medial or lateral steeper plateaus. Then when you go for the MRI, normally, usually this shape should never be looked at like normal if it exceeds more than 3 cups. لأن قلنا كل ما كان الكبس في البريفري بتكون 1 disc، لكن when you go to the center usually it give you the full nice triangle beta triangles usually of anterior and posterior holes. لكن if this cup being persistently uniform with the whole bronchial or the fibrocartilage, then usually this is to give you a clue of this meniscus. It's not normal. This is a thicker meniscus and have an abnormal shape. That is to say, this is a discoid meniscus. يبقى دائما يعني just to show you how the discoid meniscus looks like, you can see here on this MRI, this is complete, this is complete. Then here start differentiate. Let me have a better. Yeah, this is typical age. Usually find some ideal lines that say this patient is completely immature when it starts from laterally going medially, starting from the fibula here. Then this anterior and posterior horn have some communications together, and then you can find some communication together on the second slide. On the third slide, the same. This is a big discoid meniscus, and if the patient is presented with a typical lungs and he's young, near puberty, and have like this kind of pain or lung sounds, and you request an X-ray, finds a typical presentation, and the MRI shows you this finding, means that this patient has a meniscus. This is the last slide on the meniscal pathology. Sometimes the meniscal tear is trapping fluids inside, developing what we call a valve mechanism, allow fluids to get in, but preventing fluids from going out because of the pressure here. So this fluid is being trapped inside, then it starts to accumulate gradually, and this part will still form what we call a parameniscal cyst. Usually the patient has pain because of the meniscal tear, start to be aware of some swelling on the medial side in the early stages, be on and off, but it reaches a point where it becomes persistent. So this is a meniscal tear. So it is a fluid on T1, you find it black, but this is not a normal shape of diamond betelga ligament, usually intimately related to the condyle. It might be on the medial, it could be on the lateral, but it's the same mechanism. The most common site for the cyst usually is an anterior horn lateral meniscus, but sometimes you'll find it on the medial meniscus, on the long standing degenerative stairs. When you go for the T2, then you can find fluids, and then if you ask for a steer to suppress everything apart from this, except this white flare here, and this will be well delineated. Cyst. This is what we call it a meniscal cyst. Okay, this is another cyst. You see, this is an long standing horizontal tear on the medial meniscus. Start to trap some fluids inside, then it accumulates gradually until it forms this. Okay, this is another cyst from T1. It's a tear flat, and let I show you that the anterior horn lateral meniscus by far the common site for the development of the cyst, meniscal cyst. Okay, all you need is to go in to decompress the cyst, and you take the upper lip out so as to leave it like open to prevent this valve mechanism. So if Hassan then I've done with the first part, hopefully sorry that I've taken like 15 minutes more, but I have to finish with the first part because this is all about the meniscal pathology. Maybe in part 2 next time we can arrange it for the other pathologies of the knee, like the anterior cruciate, posterior cruciate, and the other pathologies of the knee. Is that fine?
Okay, thank you, Mr. Mohammed Babiker. Maybe we can leave the second part for the future lectures.
Yeah.